Okay, so with that, I am so happy to introduce our speaker. Tina Reuben is a physical therapist at University of Michigan West and a great friend. She's amazing. I've been fortunate enough to attend her support group that she facilitates in Grand Rapids, and she does a great job. And her clients absolutely adore her, and I know why. So, with that, I will turn that over to you, Tina. Thank you so much.
Okay. Well, hi everybody. As Julia said, I'm Tina Rubin. I am a physical therapist. I have been a physical therapist since 1992, so quite a while. The majority of my career, I have worked in acute care and then in outpatient as well. So I had a split role, half and half, which I really liked, really enjoyed that. I have recently been mostly doing acute care therapy, which is what kind of prompted me to move more into this management, thinking about Parkinson's patients and what happens to them in the acute care setting. And ironically, I had one patient today, slipped and fell yesterday on the ice, broke his arm, and he is in the hospital awaiting surgery tomorrow with Parkinson's. So it's a real challenge. So let's get started. All right. All right. So our objectives. Oh, how do I get rid of all the side pictures here? Let's see. Sorry.
Hey,
Um,
Tina,
yeah.
you can only see that. No one else can see it. We just see the objective screen.
Oh, okay.
Okay.
But I can't read the whole thing. Oh, there we go. Okay. So to the objectives is just three main things that I wanted to focus on is to learn how the impact of the hospitalization really impacts people with Parkinson's disease way more than it does their peers. So when you're comparing a 70-year-old person with Parkinson's to a 70-year-old person without Parkinson's, the impact of hospitalization is so much higher on that person with Parkinson's than on somebody else. Identify the complications that can arise from hospitalization, and then just maybe a couple of key interventions that can help to prevent these complications from arising. Oh, come on. Oops. Oi, oi, oi. All right, people with Parkinson's disease are hospitalized at a higher rate than the average population. They are 1.5 times more likely than the average person to be hospitalized. And I found this number, which was quite staggering to me, is that 1 in 3 people with Parkinson's will be admitted to hospital each year, which was like a 33%. That's not the end of the world. But then I thought, holy cow, that means in 3 years, theoretically, everyone with Parkinson's would have been admitted to the hospital. And that really brought it home to me, quite astounding. That's a large number of people being admitted to the hospital. People with Parkinson's have a much higher rate of emergency admission. They have longer stays once they're actually admitted to the hospital. They have higher complication rates, higher mortality rates in general, higher in hospital mortality rates. And of course, all of that is associated with much higher healthcare costs. I'm sure you've heard the saying, if you've seen one person with Parkinson's, you've seen one person with Parkinson's, right? So people with Parkinson's disease do present very uniquely. No two people are exactly the same. I'm telling this to people that know this. It makes Parkinson's a very challenging disease to treat, to manage, to recognize, even to diagnose correctly. In the past, I've spoken a little bit about DAT scans and how that works. Injecting dye into the person. The dye is taken up by the areas of dopamine in your brain. They compare that to an average and see do you have less dopamine being uptaken. And that's sort of one way to help diagnose. I know that they are working on some sebum tests, so sweat tests for diagnosis, which would be awesome. I've seen even some studies with dogs diagnosing Parkinson's, so sniffing it out. So lots of exciting things happening, but Right now, no definitive, absolute 100%, here's a test, you have Parkinson's disease. It's really a disease, it's a cluster of symptoms, maybe even a syndrome versus a disease. So people with Parkinson's face really unique challenges when they're admitted to the hospital. The nature of the disease itself, which is already difficult to deal with, complexity of home medication regimens, which are a pretty delicate balance, as I'm sure all of you know, and then the medication related policies of each institution all really makes it a challenge for patients and the providers, to be honest, when people are admitted to hospital. Let's talk a little bit about the motor and the non-motor symptoms of Parkinson's disease. So when we think about Parkinson's disease, typically in general, people think about the motor disease, right? They think about the tremor, they think about the slowness, the posture, the walking, that kind of thing. But there is a lot of the non-motor symptoms that can be that can affect people tremendously when they're in the hospital. So for the motor symptoms, these again, by no means are all encompassing. This is just the most commonly seen. Tremor, mainly at rest, mainly described as that pill rolling tremor that you might see. But we also see and hear people describing tremor of the leg, of the foot, of the head. I had one lovely lady who told me she felt like there was a butterfly inside of her that she could feel. There was like this little tremory shake. Um, there's slowness and poor movement. So we call that bradykinesia or hyperkinesia. And then, of course, postural instability, gait, balance problems, the small shuffling steps, the festination, the freezing of gait where you can't initiate a step or you get stuck once you get going. Speech difficulties, we will talk quite a lot about speech and swallowing difficulties, the softness of voice, and of course, the swallowing is a huge piece when you're in the hospital. For the non-motor symptoms, the most common, again, that we see are depression, anxiety, apathy, which can be very difficult for caregivers, especially people that are not very familiar with Parkinson's to deal with. Hallucinations, which can absolutely be made worse by being hospitalized. Again, can be caused by the disease as well as being caused by the medication. Constipation, which is again a huge problem. Orthostatic hypotension, which can actually be a cause of admission for some patients. Sleep disorders, which we know is a big problem. Loss of sense of smell and cognitive impairments. So complications that are seen at higher rates in people with Parkinson's than in their peers when they are hospitalized. So the deterioration of swallow. People with Parkinson's have at baseline already a higher rate of aspiration than normal. When they're hospitalized, they have an even higher rate of aspiration and aspiration pneumonia. And we'll get into that a little bit more detailed in a few slides. There's exacerbation of Parkinson's symptoms in general, the motor and the non-motor, which reduces your independence. So for the motor symptoms, think about things like you're rolling over in bed. Normally at baseline, rolling over in bed can be a very difficult thing for people with Parkinson's to do. Now imagine you're in a hospital bed, which is so much smaller and narrower, a different bed than what you're used to. Standing up, again, standing up from a different chair, walking in a small room, turning in a small space. There's self-care, which is different. All of this making for a much higher fall risk than normal. The non-motor symptoms that we see at higher rates, again, pain, anxiety, a lack of concentration and focus, a slowness of thought, constipation again being a big problem, delirium and hallucinations. There is also an issue with deterioration of long-term Parkinson's control. So people work sometimes for months or years with their movement disorders or their neurologist physician just to get the just right dosage of medication. And then they come into the hospital and all of that kind of goes to pieces. It can result in a permanent reduction in mobility, much more difficulty in medication management in the long term, and the pre-hospitalization regimen has to be further adjusted and tweaked once the person is discharged. There is something called neuroleptic malignant syndrome. I will admit that I have never seen this in the hospital. Hopefully that's because the people that I have working with me know what they're doing, but it's caused when there's a sudden withdrawal of dopamine medications. So Cinnamid, which is one of the most common medications that people take, carbidopa, levodopa, if you suddenly stop taking that, like cold turkey, it can cause fever, confusion, a raised creatinine phosphokinase, muscle rigidity, altered consciousness. It can even cause death. So that's a pretty serious thing. Again, I've never seen it in the acute care setting myself. And then we spoke about death. Patients with Parkinson's have a greater in-hospital mortality rate than their peers. All of these issues can lead to additional complications, and it really sets up this vicious cycle. Someone comes into hospital, they had higher risk for all of these things, falls and swallowing, deterioration of their muscle mass, they have medication side effects, mental and physical decline, decreases their independence, and then that puts them at higher risk for falling and having swallowing changes and decreasing their independence, and it kind of goes on and on, called the symptom spiral. So how do we manage some of these complications? So let's talk about swallowing, which is really just absolutely crucial. People with Parkinson's must be upright when swallowing. Now, I don't know how many of you have been in the hospital or have been visiting people in the hospital, but very, very seldom do you see somebody in a hospital bed sitting completely upright. They're almost always reclined back at, 30 or 45-degree angle. It's very hard in a hospital bed to get completely up to a 90-degree angle. People with Parkinson's, like we said, are already at a higher rate of aspiration, and aspiration is when your food, drink, whatever it might be that's in your mouth, instead of going down your esophagus and into your stomach, it goes down your trachea and into your lungs and into your respiratory system, causing pneumonia. Pneumonia is one of the leading causes of death amongst people with Parkinson's. People with Parkinson's may not be able to advocate for themselves to be put into more upright positions. So they may not be able to push the bell, call the nurse. They may not want to bother the nurse. They may not want to call the nurse aide because they feel like they're bothering them. I hear that a lot. Medications might not be giving appropriately because of how meds are administered. So if you're in a laying down position, they're giving you a sip of water in your medication, that's going to be a problem. So swallowing is a big deal. Another way to help reduce pneumonia with people with Parkinson's is frequent, thorough oral care, and we'll talk more about that. Um, Eating carefully without distractions, taking small sips and bites is important. Again, we've talked about not being able to self-feed, being dependent on others. In a hospital, it's a real system that's going on. It's like the people with the food trays come along, they put the food tray on your tray, and out they go. You may not be able to get that food tray closer enough to you. And if you've ever tried to open those little mayonnaise packets or those little ketchup packets, you know exactly what I'm talking about. It can be very difficult to do. So you might need to be, again, dependent on others. You might have to push the button and call the nurse to come and help you, whereas at home, you wouldn't be having those difficulties. With oral care as well, with cleaning mouth, you may not be able to be as thorough. So, for example, normally you use an electric toothbrush at home, and then you're in the hospital and you didn't bring your electric toothbrush because you slipped and fell and broke your ankle. You weren't really planning on coming in the hospital. And now you have to use the hospital administered toothbrush, which is just not the right thing. It might be much more difficult for you to use. You're not as thorough with your cleaning in your mouth. Or you might actually become completely dependent on somebody else. If you injured your right arm and you're right-handed, you might not be able to do it as well. So that increases the oral bacteria that's in your mouth and remains in your mouth, and that can be aspirated. So not just the food, but just even the accumulation of bacteria in your mouth makes you a higher risk for pneumonia. So considering occupational therapy evaluations when you're in the hospital for weighted utensils maybe, or any other kinds of aids for self-feeding. We also have things called inspirometers or vibropeps. If you've ever been around a hospital setting, I'm sure you've seen this. We give this to almost everybody that comes in the hospital. It's a pulmonary clearance device. So it's something that you either suck on, so you put it in your mouth and you go, take a big deep breath to try to inflate your lungs, or the vibrapep that you blow into in order to, again, try to get some vibration in your lungs. It is very difficult for people with Parkinson's. It's difficult for most people to use, period, but it's more difficult for people with Parkinson's because you might have been taught how to use that 2 days ago. You might have been taught this morning when you were having an off period and you don't remember what they were talking about, or there might have been a lot of people in the room at that moment when someone came in and showed you how to use that. So I know personally when I'm working with anybody, but especially with somebody with Parkinson's, I will give them the inspirometer and say, show me how to use that. And it's about a 50% rate of people that instead of sucking on it, blow into it. So it's something that we really need to think about, getting that really increase that lung volume. So working with speech therapists to help determine personalized swallowing tips is really important. So getting speech therapy involved. I would say really that anybody that's coming into hospital that's an unexpected admission, so not going in for a knee replacement or a hip replacement or something that you can prepare for, but an unexpected admission like a fall, fractured hip, fractured arm, whatever it might be, they really should get a speech therapy consultation immediately. May even need a video fluoroscopy swallow study to assess swallow and treat swallow problems. Yeah. Mm-mm. Here we go. All right, medications. Right medication, right dosage, on time, every time. It really is a mantra that anybody with Parkinson's should have. People with Parkinson's often will have quite complicated home regimens that might not be in the patient record. What we will see oftentimes is somebody comes into the hospital, they're admitted as an emergency admission, but their physician, their movement disorder specialist, or their neurologist actually belongs to a different hospital system. So we may not have that home regimen in our record system, and it's difficult to get. Disruption to that medication regimen, as you might know, it can be disastrous. It can take months, even years to get it just right. And then you come into the hospital, everything is disrupted. So the right medication with the right dosage at the right time, every time, super essential for people with Parkinson's. We really encourage our staff to confirm the correct dosages and timings with a family member. It's really essential. People with Parkinson's have some underlying cognitive challenges. They may not be aware of their precise medications. Maybe someone else sets up their pills for them and they don't remember, or they've come in and there's a lot going on and they just can't remember it right now. So having family around to help is really helpful. Often unknown to the caregivers. So, mostly I would say with nursing staff is the timing of medications. And we all know how imperative it is for people with Parkinson's to have their timing of their medications adhered to as closely as possible. And there are many situations where this just is not possible. So my gentleman that I had today that fell and broke his arm, he has been put on NPO, which is nothing by mouth. In order to have surgery tomorrow, he's not allowed to have anything to eat today. He normally takes his medication in applesauce and he has to have thickened water because he's having difficulty with swallow. So because he's having it with applesauce, they won't let him take it. So he hasn't had any doses of Cinnamate today, and then he's going to have surgery tomorrow morning, and then hopefully we'll get him back on his Cinnamate after his surgery. But you can imagine not having, 4, 5, 6, 7, 8 doses of your medication has been skipped. That puts people in a real pickle. Sometimes there's a medication that somebody's taking that isn't available in the hospital. So then the family member brings it in, it has to go down to pharmacy, it has to get verified, and then the patient can take it. So that results in a long delay before the patient can have that medication. Sometimes people are in the emergency room for a long time before they actually get admitted up to the floor, and they're not being administered their medications when they're down in the ED. We just this past week have had multiple people in the hallways in our emergency room because we've been so busy and so full with the snow that we've had, lots of car accidents and lots of slip and falls. There might be hospital policies that are say medications need to be given at certain times instead of what the person with Parkinson's has as a regimen for home. And then also we think about nursing convenience, right? If you think about a nurse that has 4, 5, or 6 patients that they're looking after, they have to do morning meds, they have to do midday meds, they have to do afternoon meds, they have to do evening meds. Well, somebody with Parkinson's may not want their medication in the morning when they're busy eating a meal at the same time. They may not want their medication at lunchtime with their meal. So, something to think about. Um, Especially the Cinnamate, the carbidopa levodopa. I'm sure you all know, but that should be given on an empty stomach, typically at least 30 minutes before and after. So the timing of that medication can be very difficult. I just recently had a patient that was taking Cinnamate, I think it was 6 times a day. So imagine trying to keep track of taking Cinnamate 6 times a day and then working your meals around that, and then having that nurse be responsible for administering that medication. Because when you're in the hospital, you don't have control of the medication yourself. And that nurse now has 4 or 5 other patients to look after as well. It's a lot. Um, there can also be issues with contradictions to regular medications. So, if the medical situation warrants that a medication is stopped, it's really imperative that an alternative is given as soon as possible. But really, what we prefer is that the contraindicated medication is not prescribed at all. Because, again, suddenly stopping dopamine medication can cause that neuroleptic malignant syndrome, and that can be a real problem. All right, let's talk about hospital delirium. So, a lot of people experience hospital delirium. This is not specific to Parkinson's patients, but it can be a lot worse with Parkinson's patients. So, there's many factors that can contribute to this. We call it an acute encephalopathy. So, the illness itself, infections, any kind of baseline dementia, the hospital delirium, and then any dopamine medications that are taken for Parkinson's management can cause that. Or usually, what we see, it's a combination of all of those things. So, in a hospital setting, the first step really is to identify what is the underlying process that's responsible for the mental status change. So, if somebody has come in and now they're very different than what they were at home, why? What is the underlying cause of this? So, the medications that could be at fault or could be something that we could look at would be adjusting or discontinuing some of the anti-Parkinson's medications if it's felt to be the offending agents. So something like an amantadine or a dopamine agonist, again, would not look to discontinue the levodopa because that is typically the most common medication that we see with people with Parkinson's. It's also the least likely medication that will cause an acute encephalopathy. Other medications like lorazepam, sometimes they are used acutely in the hospital setting when there's uncontrolled agitation and delirium. This is when you need an immediate response required. But obviously, the goal is to not use this on a routine basis. So if somebody is acting out, hitting, punching, etc., we might have to go with the lorazepam. We will also see anticholinergics being used to help manage tremor in people with Parkinson's. This can also contribute to a cognitive impairment. So maybe not the best thing to be taking when you're in the hospital already. Antipsychotic medications, again, these are usually only used with refractory psychosis or delirium. So when other treatment has failed, things that fall into these class of treatments, Seroquel is something that we hear quite a bit. It tends to be widely used. That's usually given when the patient is still calm enough and understanding to take medication. It's not used in an urgent, acute agitation situation. Um, we really do try to avoid, if possible, antipsychotics, the first generation, and Haldol is one of the ones that you hear about in the hospital and is given quite frequently in the hospital when someone becomes acutely agitated. Um, so we try to avoid Haldol if possible at all, because this really can result in worsening Parkinson's symptoms. What we really need to do is to provide gentle, passive reorientation to the person with Parkinson's, to their setting, explain what's going on, explain where they are, have some natural light in the room, open the blinds during the day, and then at night, maybe using something to help sleep, whether it's a melatonin or something stronger to help the person with Parkinson's have a decent night's sleep. Let's talk about the lower respiratory tract infection, so pneumonias. Again, a little bit repetition, but we've talked about early PT, OT, and speech, sitting out of bed, mobilizing, walking, not just getting to a chair, but actually walking, correct use of the inspirometers, frequent and guided oral care, and then again, the upright posture to help prevent development of pneumonia. Difficult to do in bed, so patients really, really need to be encouraged to get out of bed to a chair for eating their meals. Um, Also important to be upright for about 20 to 30 minutes after eating because of Parkinson's related gastroparesis. Okay, constipation. Oh, the big one. Everybody has some issue with constipation. I tell you, if you dig deep enough, there's enough people out there with Parkinson's that have constipation issues. This does affect medication absorption. It can be a real problem. On top of that, if you think about people with Parkinson's now not mobilizing very much, they have constipation at baseline. Now we are also giving them maybe some narcotics because they're in pain, because they've fallen and fractured their hip. That slows down gut motility. So it further increases the constipation. It can be an absolute dreadful problem. We really need to treat aggressively with Miralax or some kind of laxative or something similar to that. These do have an osmotic effect, which means that draws water into your gut. So you need to ensure adequate hydration. And that means drink water, drink water, drink water. The problem that we have is that people will say, "Oh, I don't want to drink water because then I have to go to the bathroom." Well, that's okay because then you have to get up and walk, and we want you to do that too. So, really trying to get ahead of the constipation with some Miralax and hydration is super important. Mobilization, upright posture. Again, if you have constipation, you have an increase of gastroparesis as well as an increased chance of having a bladder infection. Speaking of bladder infections, so urinary tract infections, ensure that constipation is adequately treated. Otherwise, that pressure on the bladder can cause problems. Ensure adequate hydration. So, again, the importance of drinking. Um, if people are being admitted to the hospital because of recurrent bladder infections or UTIs, it might be something to consider a community-based pathway for management of that. So maybe if you're someone who's had like 4 admissions to the hospital this year because of a UTI, maybe we need to have more regular check-ins with the PCP, primary physician, or maybe the caregivers need to be educated a little bit more on what are the signs and symptoms and how to treat a urinary tract infection at home. Maybe home care needs to be started, so a nurse aide or a home health nurse can come out to the house and that kind of thing. So people with Parkinson's are at higher full risk than the general population. Things that we have to think about are orthostatic hypertension, which is when you are changing position. So if you're going from a supine laying down position to a sitting position, from a sitting position to a standing position, your blood pressure drops. It can be very quick. We have a lot of people that will be admitted because they've fallen, not because they tripped or lost their balance necessarily, but because they passed out. It's not always a passing out completely, but it's the significant drop in blood pressure that causes someone to kind of blink out for a few seconds. We really need to ensure PT, OT, speech interventions again because of the fall risk. Consider a bone health assessment when someone is in the hospital, just to really see, what is the condition of your bones? Are your bones strong or not? Do we need to do something medication wise there that could help? Using aids to mobilize patients when they're in hospital. So it might be a walker, it might be a U-step, it might be a cane, etc. Again, best positioning for feeding and then use of bed and chair alarms so that if we have someone in the hospital who is more confused, delirious now at this point, we don't want them getting up on their own because that will definitely result in another fall. We have chair and bed alarms for them. So, orthostatic hypertension. With hypertension, we have to ensure adequate hydration. So again, we really want you to drink. But drinking too much water and not having enough salt intake can dilute your sodium, and that can cause all kinds of problems too on a metabolic level. So adequate hydration and then adequate salt intake at the same time, super important. We really need to rationalize and think about our antihypertensive medications, so your blood pressure medications. When you're in the hospital, we need to think about when and how are we measuring blood pressure, and then how are we giving blood pressure medications. I had an experience with this recently with a patient where in supine, laying down, his blood pressure was really high. As soon as we sat him up, he would drop by 30 or 40 points. And when he stood up, he would drop again by another 20 or 30 points. So even though he was in the, high 180s when he was in supine, as soon as we changed his position, his blood pressure would drop. So if we're giving this person his blood pressure medication because, oh my goodness, his blood pressure is so high, now when we sit him up or try to get him to the bathroom or the commode, this poor man was passing out. So the physician actually, I remember very boldly in the chart put, do not give antihypertensive medication. Change the patient's position first. If he's still hypertensive, then of course we're going to be giving antihypertensive medications. But if he changed the position and the hypertension goes away, well, then maybe we need to look at changing position more often, more frequently, rather than giving the blood pressure medication. The other thing that people can consider is compression hose and even abdominal binder if needed. There is a medication called Florinef that can help with this as well. Um, and this is a very interesting thing that there are other medications that can contribute to orthostatic hypertension. I had a case recently of a gentleman that was started on Flomax. He had only been on it for 3 days and he had passed out twice at home. They admitted him, they did a full cardiac workup on him, thinking that there was something cardiac related with him. They stopped his Flomax, and within a day, his hypotension had gone. He wasn't dizzy, he wasn't passing out anymore. So, needless to say, they found a different medication for him, and he was not taking Flomax anymore. Okay, so just a few key interventions for mobility. I'm sure you've all heard some of this before, but it's good to remember. When you're moving, large amplitude movements, lots of effort. So with a sit to stand, something like 1, 2, 3, and go works well for getting up from a chair, asking the person with Parkinson's to really give it all they've got, really give big effort, reach towards a target, get your nose over your toes, use your arms, a big push up and go. So in bed, I will give patients a target. I'll say, okay, we're going to bend your knees. We're going to roll over to the right side. I want you to grab the rail. So bend your knees, left hand, ready? 1, 2, 3, and go. So again, having that momentum and setting them up for success can really help. Now in the hospital, sometimes we do have to use a bedpan if somebody is pre-surgery, hasn't had their surgery yet. We try to minimize the use as possible, but sometimes it's unavoidable. Again, the best way to do that is bending knees, push with arms and elbows, and do like a 1, 2, 3 lift, asking for best effort, big lift. Um, Something that has worked really, really well, and I hope a lot of you are using this if this is something that is a problem for you, is if you are getting stuck, if you're freezing, if you're not able to initiate that step, um, I'll have my patients sit on the edge of the bed and stand. And then once we're standing, say we're walking to the toilet or we're walking to a chair, or we're walking to the door, whatever we might be, I'll have them estimate how far that's going to be. How many steps do you think it's going to take for you to walk from here to there? The number of steps doesn't actually matter. It doesn't matter if they get it right or wrong. The thing is that as soon as they start thinking about the number of steps they're taking and counting them out loud, it really helps them to take much bigger steps, and that fascination just stops. So I will often say, how many steps from here to the toilet? The patient says, I think it's going to take me 5 steps. I'll say, okay, show it to me then. Let's go. Ready? 1, 2, 3, 4, 5. And if it takes 10 steps, that's fine. Just keep counting. It doesn't matter. But it really works super, super well for those people that get stuck. Another thing that you can do too is some retro stepping. So if you're stuck, fascinating, you're going forward, you're kind of tipping, stop, take a step backwards, and then go forward again. And that seems to help as well. The other thing that sometimes we will do is, because of the rigidity through the trunk, is just do some rotational movements, sitting edge of bed, kind of get loosened up a little bit, and then start getting up and moving. So big long marches, big long steps, excuse me, and then marching, stomping feet. So I'm sure you've probably experienced this yourselves, but with turning, with tight spaces, so crossing thresholds, going through narrow doorways, backing up, squaring up to sit safely, sitting prematurely. How many times have I told people this? Oh my goodness. People that turn and sit and half the butt cheek's on the toilet and half the butt cheek is off, or they're going to turn around and sit and they don't quite make it on the chair. They're like three-quarters of the way, but not the full way on the chair. So something like stomping your feet in place while you're turning around, that can really help to get squared up to the chair. Again, using appropriate assistive devices can be super helpful. U-step walker with the laser or cane with the laser. That's not always what people have at home. So sometimes we'll use a TheraBand around a walker, or even just any kind of a piece of tape around a walker and have them kick. And again, targets can be very useful. At the hospital that I work at, we have some round, flat discs that we can just throw on the floor. They're just like rubber discs, brightly colored, like luminescent green and yellow and orange and pink. Throw those down on the floor as we're walking and have the person step on the targets as they're going. Super helpful. Again, it encourages big, long steps. And then again, music and singing or humming a tune that is familiar and easy to remember, that can help with movement as well, and help that fascination or that getting stuck. All right, we've talked ad nauseum about swallowing, but here we go again. Some key interventions for swallowing. People need to be awake. They need to be stimulated, engaged, have an upright posture. Again, preferably in the chair versus the bed. Need to be up for 20 to 30 minutes after meals. Not only the gastroparesis, but reflux. Oral care, oral care, oral care, if you haven't heard that enough. Assist with tray setup and assist with feeding if needed. Minimize distraction during feeding. Provide encouragement and supplements between meals so that people can get their target intake for nutrition and hydration. One thing I will say here is hospitals tend to have supplements during in between meals that are high in protein. So the protein, like the power shakes. So be careful. If you've got the power shake and you're sipping on that throughout the day and you're also taking your Cinnamate, you got to watch that. You also should be having some individualized notes or signs in the room from the speech therapist for each individual person, because again, everybody is so unique in what they might need for their swallowing. Okay, the on and off impacts of medication. I think this is something that most caregivers really are not aware of at all. When I've spoken to the nursing staff in our hospital, they don't even know what on and off means. Most people with Parkinson's will understand exactly what on and off means. Um, but basically, it's periods of times where your medication is most effective was an on time. A period of time when your medication is less effective is an off time. And I know that that can change very quickly for some people. This can be perceived by the caregivers as a person giving less effort or being non-compliant. So the nurse might say, well, yesterday Joe got out of bed and he did just fine. Today he won't even roll over and get up. I don't know. I don't know why he won't do it. Well, maybe yesterday when you got Joe out of bed, it was on an on time. And today you're trying to get Joe out of bed and it's an off time. So of course it's going to be more difficult for him. And he might not be able to explain that. Um, the other thing to think about is that on and off times impact all symptoms of Parkinson's, not just mobility. So it's not just an impact on the movement. People might become more agitated. Swallowing might be more compromised. They become more anxious. They become more tremory. They have more difficulty with sleep during their off times. So if possible, if you can advocate for yourself or your family members can advocate for you, having testing scheduled during an on time is the best thing to do. So if you're going to go for an MRI and you're on an off time, good luck trying to get an MRI because you need to lay still in that machine. So on times, less tremors makes it much easier. People with Parkinson's also experience dyskinesias, right? Which are those involuntary movements that you can have from Cinnamate. That can make things much more difficult for people, for staff as well, for like lab draws, for IV placements, again, MRI, CTs, etc. And when we're urging people when they have a dyskinesia or they have tremors and we're saying, try to hold still, try not to move, that can actually make it more difficult because it makes them even more anxious when they're trying to control their movements, which is difficult. So depending on the acuity of the situation, how urgent it is, we could look at maybe altering the levodopa dose and giving it more frequently to minimize the off times. Again, tend not to want to mess too much with the home regimen if possible. Amantadine is another medication that can help with dyskinesias, but we said it's an anticholinergic and it does have some risks. But honestly, if you can advocate just to have a better time for a certain procedure, if someone knows that they will have their medication again in an hour and then they'll have like an hour and a half of being on, maybe they can come back and draw labs at that point, or maybe the IV could be placed at that point. But sticking to schedules that people have from home is very helpful as well. If someone naps every afternoon or naps every morning, that's super helpful. Trying not to awaken someone with Parkinson's during the night because they can be aggressive, they can act out. We all know that people with Parkinson's can have real issues with sleep and acting out very vivid dreams. In the hospital, we do try to use the same words and phrases that work for a particular patient. So we will talk to the family and find out what works best for their loved one and try to mimic that as much in the hospital. So if the family always says big steps, then we're going to say big steps. If the family always says use a loud voice, then we're going to say use a loud voice. And it's super helpful sometimes to have signs in the room so that the nurse, the respiratory therapist, the physical therapist, the occupational therapist, everybody is saying the same words. And then overall, I would say this is true for everybody in the hospital, not just for people with Parkinson's, but less words and simple commands are much easier. So in summary for this, we try to keep schedules as similar to home as possible, not just with medications, but with activity as well. So natural light, reorientation to the place and the situation, ensuring right medication at the right dose at the right time every time. Be aware of other medications and their interactions with their Parkinson's disease. Be aware of on and off periods. Mobilize, mobilize, mobilize. Out of bed, follow all the safety guidelines for swallowing. Make sure that they are using pulmonary clearance devices and watch for that orthostatic blood pressure and dizziness. This is just a little test I had to have for the presentation that I did for my hospital, so I'll skip through that. I did want to just mention briefly that Parkinson's.org, so the National Parkinson's Foundation, they have a kit that you can get from Aware in Care. It's super, super helpful. I would highly encourage everybody to go onto that website and get that kit ahead of time. This is something that you want to have and be prepared for. It helps you to understand the risks that are associated with a hospital stay. It gives you the tools that you can play an active part in your care. It helps you be plan for a hospital visit, whether it's a planned hospital visit, like a total knee replacement, or whether it's an unplanned hospital visit. You've got a strategy. So it helps you to develop the best strategy possible for the hospital. It is a free kit. It comes in a little black bag. And it's called Aware and Care. If you go to the Parkinson's Foundation, super easy to get, just apply, they will send it to you free. Really nice little kit. These are my references, and I have a little video. Hopefully this is going to work for us, Julia. This is my patient Fred and his wife Sharon, and they're just describing a little bit about their experience in the hospital. So hopefully you can all hear this and it will work.
Out for a nice bike ride on the pathway, came up to it and had to wait for traffic. Traffic cleared, we started out. I started, he hit my bike and we fell over. And he had 4 broken ribs, had a small laceration on his spleen. And obviously ER came and went to the hospital. I gave the nurse a list that I carry a list with me of all his medications, surgeries, all his health information.
And you carry that all the
I carry this all the time. If we go for a walk, I have this my license, insurance cards, money, just in case.
She expects you to fall over.
She expects you to fall over. So pain was a real issue.
Oh, yeah. And he had a pad on his back for the pain, so he was constantly getting it.
Okay.
And other than that, he was doing, pretty good.
Okay.
He had the tremors and, stuff, but not as bad.
Okay.
And at that time, he had his DBS implants.
On admission, was there a break in the medication? Did they not give it to him for a certain period of time, or were they pretty good about it right off the bat?
There was a mix-up in the medication.
There was mix-up? What was the
Yeah.
mix-up?
Well, they didn't give it to him right away because they didn't know if they
It's
had
like
to
I
do
couldn't get
surgery.
approval to take medication.
So, yes, he had gone without his meds, and at that time, I had some with me, but they wouldn't let me give them.
Right.
And stuff. So he was without his meds, so obviously he was off. The biggest problem was getting the meds on time because,
On your schedule from home? Your home schedule?
yes,
Okay.
which could have, I was okay to being adjusted and stuff to schedule, but as long as he was getting them every 4 hours, which he really wasn't because, they're busy. They can't always come down. But then he started hallucinating, and fortunately, I stay with him when he's in the hospital. He started hallucinating and argumentative, which he never is. And it got to the point
Nice
where
guy.
they had to send in another person just to watch over him. He was hooked up to IVs. I had given him the list of how he took his meds and the doses. He was on 2 different doses of carbidopa, levodopa. Unbeknownst, until like the night before we were being discharged, 2 nights before I can't remember. But for some reason, I asked what dose, and it was double the dose that he should have been taking. And with the hallucinations and everything, I'm thinking that's part of the reasons why. So now whenever he falls and goes to the hospital, I always ask the nurse, what dose? So that I know for sure he's getting, but the key thing is you gotta be, they can't do it, he can't do it. Somebody's gotta be able to be there almost all the time to make sure that treatment is being given when it should be given and how.
And did you get back to your previous level of function?
Yeah,
What would you say?
We don't bike ride anymore.
Yeah. So that was the last bike ride?
Yeah, that was, well, yes. I personally think it's the beginning of a downward trend
Okay.
because he's been, since that episode, he seems to be going down more and more.
Okay. No more hallucinations or anything like that?
well, a year later, I fell in a hotel room and I broke 1 rib. But I toughed that one out.
Is there anything else that you want us to know or would want other people with Parkinson's to know if they're hospitalized? What would you say is important for them to know, important for them to?
Keep track of the medication that they're giving. Okay. And forcefully tell them that every 4 hours they need their medicine. Because he's been in hospital since then where he's fallen and ended up. And a lot of nurses don't seem to know how to deal with the Parkinson's patient as far as meds.
Okay.
And that was the one thing I learned when we were in the hospital all those days. Because I don't think if he would have had the right dosage, I think he would have been out of the hospital sooner.
Sure.
Yeah. So definitely somebody has to be there keeping track of the meds.
Okay. Fred, is there anything else you would add? You don't remember much of this hospital stay.
I remember a lot of people coming in.
A lot of people coming and going.
Yeah. And you get confused.
Sure.
But other than that, that's about it.
Okay. All right, and that is all that I have. So happy to take any questions.
Thank you, Tina. That was great. If anybody has any questions, please feel free to raise their hand or put it in the chat. I would just like to add a couple of things if it's okay. I think it was an excellent presentation. You hit on every single point. Um, I will tell you that when I went to nursing school, when we learned about Parkinson's disease, it was a half a chapter. That's it. And they don't really study a lot about Parkinson's disease. And that still is true to this day with nursing graduates. And I want to encourage people to, approach the nursing staff with maybe some words, not yelling or screaming at them, not making a scene. I mean, they have rules and state laws that protect them regarding medication administration. So it's nice to say, listen, I just want to tell you about my husband or my wife or my dad. Um, if he does not get his medication on time, you may not be able to understand him. You may not be able to move him. He may not be able to eat. So, giving his medication on time or as close as possible on time will make your job easier. And trust me, they appreciate that. The nursing staff, nurses are there because they want to help, right? And I think it's important to have that conversation. The other thing that I just wanted to share, and I've shared it in the chat box, there is a document that we have available at the Michigan Parkinson's Foundation. It's called Critical Information for Hospitalization. And I tell people that you should print this off and put it on neon paper. And you should tape it to the door of their room. You can't give it to them in a chart. Everything is electronic now. They can't read it. But if you have this plastered in neon on the door, it's a great tool to use because it talks about that your own personal characteristics, what your symptoms are. I mean, someone may not know that drooling is a part of Parkinson's, and they may think you're having a stroke, and they may call an ambulance or whatever. Having this information available to educate, unfortunately, is our role with Parkinson's. And so I just wanted to share that with you. And we will post this to YouTube in a couple of days or tomorrow. It just depends on when we can get it uploaded. But I'm happy, and Tina, I'm sure happy to answer any other questions that people may have. And just to unmute yourself. Oh, Kim said, regarding scheduled visits for colonoscopies.
What I want to know was whether there would be any special precautions that one should take before one goes in for a colonoscopy.
I go ahead.
I was just going to say, I think it's imperative when the nursing staff, the surgical nursing staff calls you to schedule your time to arrive, what you should wear, what medication you should or shouldn't take, to really take the time to go over this again with every phone call that comes in from the nursing staff, because I think they can flag and alert your chart.
Mhm.
And I also think that that conversation might even need to take place earlier with the physician to ask about anesthesia and Parkinson's and what anesthesia are they administering knowing you have Parkinson's. I mean, anymore, I think they're very safe. Everybody needs a colonoscopy over the age of 50, I think is what it is. Um, and but it's worth having the conversation for sure.
I just add to that too is just remember that post procedure, you will be a little bit groggy. You may not remember everything that's going on. So having somebody with you that can physically assist you with walking, transferring, getting in the car, going up the steps, super important. I know my husband had his, and he didn't remember a single thing till we got home. He had no idea what was going on, and he doesn't have Parkinson's.
Um, the other thing that I wanted to also mention, and I worked at Henry Ford Hospital for 26 years in the surgical suite. So we would often see these. I mean, I worked with all the Parkinson's patients, so this was my area. But I want to remind people that if you come into the hospital, yes, you should bring your medication, but bring it in your prescription bottle. Don't
Yeah.
bring it in your Sunday through Saturday flip up pill box.
Mhm.
That they will not look at it. It doesn't mean anything. And why I say it's important for you to bring your medication to the hospital is that each hospital has what's called formularies where they have a list of medications that they approve for. Each hospital is different.
Mhm.
For example, Rytari was not on formulary at many, many hospitals, and people were prescribed Rytari and then they couldn't get it. So if you bring your medication in your prescription bottle and that medication is not on formulary at that hospital, they will take that prescription and they will be able to administer it, up from your prescription until they get an order in or whatever, whatever their process is in the pharmacy. But I think that's super important to bring it in the original pill bottles.
Good point.
I think Lori has a question.
Hi, I'm Lori, and I happened to be reading my email today and saw this notice as I was sitting at my dad's bedside. And my
Oh,
dad has Parkinson's. And unfortunately, he rolled out of bed the other day on Monday morning and landed on his forehead. Has a huge hematoma because he was on blood thinners, he was on Eliquis, and some bleeding in his brain, but that's small. They're just watching that. Um, but this discussion has been fantastic. I really appreciate it. I'm a physician, and yet I don't have many Parkinson's patients. I do have a couple, and then obviously intimately involved in my dad. And I, there's so much information in here that was so good. I can't wait to watch this again. Um, but my dad's really like today he was really struggling. And on Monday, PT came in, they worked with him, he walked down the hallway. Today, he didn't even want to sit in the chair. And I think he has gastroparesis. I think I asked before I left, just before I got on this webinar, to, to give him a suppository to try to get things moving on him because he is, abdomen's a little distended. And I think that's why he doesn't feel well today. But it is a struggle to change, to keep all these factors in mind. You know, here we are most worried about his brain, but now I think it's his GI system that's really what we're struggling with. And PT didn't come to see him today, and hopefully all this will turn around. But I did want to note that he takes his meds in an unusual circumstance because he does 4 times a day, but he evenly spaces them every 6 hours because he frequently gets up in the middle of the night to pee. So then he will take his middle of the night dose. Um, So he normally takes it 8 to 8, yeah, like 8 to 8 2. And so he had an episode today where his oxygenation really dropped very suddenly, and they struggled with getting it back up. And it was this very sudden change. And as we were reviewing meds, I said, well, when are you guys actually giving them to him? And they told me 8282. And I was so impressed because that's not a normal cycle for hospitals to give meds on. Yet at Troy Beaumont, that's what they were doing for him because they realized how important it is to keep the Parkinson's patients on their normal meds. So I really appreciated that. Then I was able to tweak something on that for them that I didn't have on his sheet because I hadn't had it completely updated. So I just wanted to share that with the group. And I'm so appreciative. I happened to just notice this because I don't usually get on these webinars, and that I can't wait to rewatch it because it was such a wealth of information.
Good.
Good. Come back every month.
I will try. I will very much try. Thank you so
Well,
much.
thank you so much. And we are certainly sending well wishes to your dad.
Thank you.
One of the reasons might be, you had mentioned that PT hadn't been there. It's so important for them to move, to
Yeah,
move around.
it was fascinating to me because day one, Monday, he fell, has this huge hematoma, has some brain bleed, small, but they got him up, they walked him down the hallway. But in ICU, they often don't see him every day. They often see him every other day. So they didn't see him yesterday. And then last night he got moved to a general floor. And then when he had this respiratory issue today, they moved him to a step down from the ICU called PCU, Progressive Care Unit. And they had seen he had this issue. So they bypassed him and said, we'll come back later in the day. And then they never did. So surely he'll be on their list tomorrow. But I'm like, oh my God, he looks so different than he did 2 days ago. It's really quite phenomenal to me. And I'm like, now what else is going on?
Lori, just something that might help to advocate too is oftentimes PT and OT will come together on the first visit.
Mhm.
Well, maybe they could alternate days, maybe OT one day, PT one day, so that he's at least getting something every day. We try to do that
Yeah,
at our hospital so that it's
that's
not.
a really good point. He was actually in a month ago, and he hasn't been hospitalized but overnight ever in his lifetime. And so now we've been in twice in a month. And he did go to subacute rehab, which I did take all his meds to in their bottles, and they did need to use some before they got them in, and some they never got. So they had to continue to use his own. Um, but last time he was in on the general floor, they came every day and they came separately. So I think it's just a weird circumstance that's happened this time, and maybe he doesn't feel good because he's not been moving at all.
Yeah.
Yeah,
Like
100%.
yesterday, we could get him up in the chair and everything, and today he just refused. It was really, and I know I should push it, but it was such a struggle that I just wanted him to be at peace because he said he had a really rough night, and then this whole event this morning with destatting on us, and
Yeah.
yeah, he went from being on room air to a non-rebreather mask for at 15 liters. And then within an hour, he was back off. He was back down to 2 liters, but it was crazy. It's crazy.
Well,
But I appreciate your
just
good wishes.
being in the hospital, is not great for people with Parkinson's, and we want to do everything we can do to try and keep them out. And so,
Yeah,
I think the number one reason for admission to for people with Parkinson's is because of falls.
Mhm.
And usually it's because many people feel like they don't need to use their assisted device. Maybe they don't need to use their walker or their cane, or I'm just going from the couch over to this part. I'm not going to need it. And you might move too fast. You might be in an off period, whatever the case may be. And so I just want to advocate for everybody to slow down, think about your movement that you're making, and use your assisted devices if you need them. Stay out of the hospital if you can.
very, very true. Yeah.
Any other questions that we have out there? I don't see any. Well, I can't thank you enough, Tina. As usual, Tina is a fantastic